Good morning. Today I will briefly discuss about obesity. As we know that now obesity is an emerging health problem in the India. So how will you identify obesity? For that we have to calculate the BMI, weight in kg by height in meter square. About 23 is the overweight. About 27 is the obesity. About 35 is the severe obesity. Otherwise, rather than we can plot in the growth charts, it will give the overweight and obesity. So what are the main important features after seeing obesity child? We have to see the three reasons. First thing is the height. So obesity child, if his age appropriate height, it means is between third and 97th centile. Mostly the cause is the nutrition. This is called tall obesity. Tall means is not become a tall stature but is in a normal range. Second one, short obesity. It means obesity child height is less than third centile is the short obesity, mostly is the endocrine cause. Third one is any obesity child with dysmorphic face, hypotonia, then you have to think for the genetic causes. So this is the main screening we have to do in the OPD. Height and developmental milestones and the dysmorphism. So coming to the nutritional thing. So as we know that child height is a appropriate, but weight is the obesity range. These are the nutritional causes. These childs doesn't require that much of evaluation. Second, I told you that children with obesity with short stature, mostly endocrine, is a cause. Among the how to rule out the hypothyroid, Cushing syndrome, pseudoparathyroidism, growth hormone deficiency. The routine investigation how to send T4, TSH, calcium, phosphorus, parathermone, and cortisol and overnight dexamethasone suppression test. There are genetic causes. Three genetic diseases are the most common obesity. Prader-Willi, Bardet-Biedl, Alström syndrome. Among this Prader-Willi, we can clinically by history we can diagnose. Child has a feeding issues in the first 1 year because of severe hypotonia. First 1 year, child has a feeding issues and failure to thrive. First year onwards, child develops hyperphagia and child becomes the overweight and obesity rates. So Prader-Willi child has a hypotonia preceding history of failure to thrive. Whereas a Bardet-Biedl has like a they have the vision loss and type 2 diabetes and polydactyly will be there. Alström's also again has a vision and hearing loss and type 2 diabetes. For genetic causes, we can go for the next generation sequence. There is a Prader-Willi, we have to do the methylation studies. Okay. Then routine follow up after 10 years. We have to see for the other metabolic issues like hyperglycemia, hypertension, hyperlipidemia. Any obesity child beyond 10 years, we have to do all these things. Fasting blood glucose and postprandial blood glucose, HbA1c, lipid profile, and hypertension screening. These are the important things. Two physical examination points never miss in obesity child. One is the acanthosis nigricans. This is nothing but the blackish brown pigmentation either around the neck or armpits. It indicates the free insulin. So excessive insulin causes proliferation of the cells there. Second one is the buffalo hump, nothing but the deposition of the fat between the two shoulders. So acanthosis nigricans, buffalo hump, both indicates like a metabolic syndrome. They are more from the type 2 diabetes. So how will you manage? So the drugs are surgical management not decided by pediatrician. You have to refer the endocrinologist. One of the drug available known as the early start. Coming to the what pediatrician should do. So we have to advise the diet and we have to tell them the fat reduction. We have to tell them 5-2-1-0 rule. So 5 means 5 servings of the fruits and vegetables. 2 means less than 2 hours screen time. 1 means 1 hour physical activity. 0 means 0 sweet and sugar beverages. The main role is follow up with them and dietary restriction, ask them to do all these things. If they are not responding to the above things, we have to advise medical management and the surgical management. Thank you.